Welcome back. This is episode 3 of Hypokalemia series, and today we are tackling Bartter syndrome and Gitelman syndrome. Both of these cause hypokalemia with metabolic alkalosis. Both have normal or low blood pressure. Both involve salt wasting, and on boards, they love to test whether you can tell them apart. The secret? It comes down to one test, the urine calcium. I call it the calcium trick, and once you understand why it works, based on where in the nephron the defect is, you'll never confuse them again. Quick recap of where we are. In episode 1, we built the 3-door model: renal loss, renal loss, transcellular shift, and learned to use the urine potassium to creatinine ratio as our sorting hat. In episode 2, we went deep on transcellular shifts, thyrotoxic periodic paralysis, familial hypokalemic periodic paralysis, the DKA paradox, and refeeding syndrome. Now in episode 3, we are in the renal wasting camp. The urine potassium is high, above 15 milliequivalents per gram, meaning the kidneys are inappropriately dumping potassium. And specifically, we're looking at 2 genetic tubulopathies that cause this: Bartter and Gitelman. Both Bartter and Gitelman are inherited salt-wasting tubulopathies. What does that mean? There is a genetic defect in a sodium transporter in the kidney, which causes the kidneys to waste sodium chloride into urine. This sodium chloride wasting leads to chronic volume depletion. The body senses its volume depleted, so it activates the renin-angiotensin-aldosterone system. You get secondary hyperaldosteronism. Renin is high, aldosterone is high. And what does aldosterone do in the collecting duct? It reabsorbs sodium, but at the cost of excreting potassium and hydrogen. So you get hypokalemia and metabolic alkalosis. And because these patients are volume depleted, not volume overloaded, the blood pressure is normal or low. The key to understanding these syndromes is knowing where in the nephron the defect is. Bartter syndrome is a defect in the thick ascending limb of the loop of Henle. The specific transporter is NKCC2 channel, the sodium-potassium 2-chloride cotransporter. Now here's the mnemonic that makes this stick. NKCC2 is the same transporter that furosemide blocks. So Bartter syndrome is essentially like being on a loop diuretic permanently. Think about what furosemide does to a patient: volume depletion, hypokalemia, metabolic alkalosis. And this is the key. What does it do to urine calcium? We'll answer that in a moment, but first, let me show you the other side. Gitelman syndrome is a defect in the distal convoluted tubule. The transporter is NCC, the sodium chloride cotransporter, and this is the same transporter that thiazide diuretics block. So Gitelman is like being on a thiazide permanently. Now both of these cause the same downstream effects: salt wasting, volume depletion, secondary hyperaldosteronism, hypokalemia, metabolic alkalosis. So how do you tell them apart? Here's the key. Think about what furosemide does to urine calcium, and think about what thiazides do to urine calcium. Furosemide increases urine calcium. It causes hypercalciuria. Thiazides decrease urine calcium. They cause hypocalciuria. And that is the calcium trick. So now let me show you what's actually happening inside a thick ascending limb cell. So this is the thick ascending limb cell. On the left is the tubular lumen, and the urine side. On the right is the blood. Look at the apical membrane. The side facing the lumen, NKCC2, sits here bringing in sodium, potassium, and 2-chloride ions from the lumen into the cell. But here's the crucial step: that potassium doesn't stay in the cell, it recycles out into the lumen through the ROMK channel. And when that positively charged potassium ion goes back into the lumen, it creates a lumen positive voltage. That positive voltage is the driving force for paracellular calcium reabsorption. You can see it at the bottom. Calcium moves between the cells, driven by the electrical gradient. No active transport needed. It's purely passive, driven by the voltage that NKCC2 and ROMK create together. On the basolateral side, sodium-potassium ATPase pumps sodium out to the blood, and chloride exits through the CLC-KB channel. Now, what happens when NKCC2 breaks? This is Bartter syndrome. NKCC2 is broken. Look what happens. The transporter is crossed out. It can't bring sodium, potassium, and chloride into the cell. Without those ions entering, there is nothing for ROMK to recycle. No potassium recycling means no lumen positive voltage. And without that voltage, calcium cannot be driven paracellularly. Look at the bottom. The calcium arrow is blocked. Calcium stays in the lumen and it gets excreted in the urine. That's why Bartter causes hypercalciuria. The entire calcium reabsorption mechanism in the TAL depends on NKCC2 functioning normally. You break NCC2, lose the voltage, lose the calcium. The consequences box over here on the right summarizes it. Sodium chloride wasting leads to volume depletion and secondary hyperaldosteronism. No potassium recycling means the lumen positive voltage is lost and calcium can't cross paracellularly, leading to hypercalciuria, nephrocalcinosis, and kidney stones. This is the same reason furosemide causes hypercalciuria. It blocks NKCC2 just like Bartter does genetically. Now let me show you the DCT cell for Gitelman. So this is the distal convoluted tubule cell downstream from the TAL. The apical membrane has NCC, the sodium chloride cotransporter. It's simpler than NKCC2, just sodium and chloride, no potassium. But notice two other channels on the apical membrane. TRPM6, the magnesium channel, and TRPV5, the calcium channel. Both of these are transcellular, meaning the ions go through the cell, not between cells. Here's important connection. NCC activity actually regulates TRPM6 expression. So when NCC is working normally, it maintains TRPM6 on the cell surface. The cell says NCC is active, everything is fine, keep TRPM6 expressed. On the basolateral side, the sodium-potassium ATPase handles the sodium, CLC-KB handles the chloride, and NCX1 exports calcium to the blood. Now, what happens when the NCC breaks? This is Gitelman syndrome. NCC is broken. First, sodium and chloride can't enter. That's your sodium chloride wasting and volume depletion and secondary hyperaldosteronism, just like Bartter. But now look at TRPM6. Because NCC is broken, TRPM6 gets downregulated. The cell loses its magnesium channel. The expression drops. And there is even evidence that DCT cells undergo apoptosis over time. Magnesium can't be reabsorbed. You see the X on the magnesium arrow. That's your hypomagnesemia. And what about calcium? Here's where it gets interesting. The NCC defect causes volume depletion. That volume depletion triggers increased sodium and calcium reabsorption in the proximal tubule upstream, so less calcium even reaches the DCT. Look at the green box in the lower left. Proximal calcium reabsorption goes up. The result, less calcium in the final urine, leads to hypocalciuria, no stones, no nephrocalcinosis. So the calcium stories are completely different. In Bartter, calcium can't be reabsorbed in the thick ascending limb because the voltage is gone. In Gitelman, calcium is reabsorbed more in the proximal tubule because of volume depletion. Opposite effects, different mechanisms, same diagnostic trick. Check the urine calcium. Now let me formalize this as the calcium trick. In the thick ascending limb, calcium reabsorption is paracellular, meaning calcium passes between cells, not through them. This paracellular calcium transport depends on a lumen-positive electrical voltage. And where does that voltage come from? It comes from NKCC2 activity. When NKCC2 brings sodium, potassium, and chloride into the cell, the potassium recycles back into the lumen through the ROMK channel. This creates a positive charge in the lumen, which drives calcium and magnesium paracellularly. We are rephrasing this so that it gets embedded in our minds. When NKCC2 is broken, as in Bartter, that lumen-positive voltage collapses. Calcium can't be reabsorbed paracellularly, so calcium pours into the urine. The result is hypercalciuria, and over time, that leads to nephrocalcinosis and kidney stones. Now, in Gitelman, the NCC defect in the DCT causes sodium chloride wasting. This leads to mild volume depletion, and that volume depletion actually increases proximal tubular reabsorption of everything, including calcium. So, less calcium reaches the distal nephron and the urine. The result? Hypocalciuria. No stones, no nephrocalcinosis. The thresholds to remember: urine calcium to creatinine ratio above 0.2 suggests Bartter. Below 0.14 suggests Gitelman. One test, one answer, that's the calcium trick. Let me walk you through a case. A 20-year-old man found to have nephrocalcinosis on abdominal imaging. His history is significant for premature birth, failure to thrive during infancy, growth retardation during childhood, and chronic weakness with polyuria. These are classic features of Bartter syndrome, which typically presents early in life. His labs are positive for potassium of 3.0, bicarbonate 34, so hypokalemia with metabolic alkalosis. Magnesium is actually normal at 1.9, and his blood pressure is also normal at 112/72. So we have the classic triad: hypokalemia, metabolic alkalosis, normal blood pressure. Now the calcium trick. The urine calcium to creatinine ratio is 0.25. That's well above the 0.14 threshold. This is hypercalciuria, and he has bilateral nephrocalcinosis on ultrasound to prove it. Hypokalemia, metabolic alkalosis, hypercalciuria, nephrocalcinosis. This is Bartter syndrome, the NKCC2 defect in the thick ascending limb. Let me give you more clinical depth on Bartter. Bartter typically presents early. In the most severe forms, you see polyhydramnios in utero because the fetus is making enormous amounts of dilute urine. Neonatal presentation includes prematurity and severe salt wasting. During childhood, failure to thrive and growth retardation is seen, and nephrocalcinosis is often the finding that prompts the workup. There are actually 5 subtypes. All are autosomal recessive. Type 1 is NKCC2, the most classic form, the one we've been discussing so far. Type 2 involves ROMK channel, the potassium recycling channel. Type 3 is chloride channel CLCKB. This is sometimes called classic Bartter because it tends to present a bit later in childhood rather than neonatally. Types 4 and 5 are rarer. For boards, you mainly need to know type 1 NKCC2 the association with prematurity, nephrocalcinosis, and hypercalciuria. Treatment centers on salt repletion and indomethacin, a prostaglandin synthesis inhibitor. In Bartter, prostaglandin E2 levels are elevated and contribute to salt wasting. Indomethacin reduces this. You also give potassium sparing diuretics at times like amiloride to limit potassium losses, plus oral sodium chloride and KCl supplementation. Remember, these are salt wasting tubulopathies, so you need volume repletion before you move to potassium sparing diuretics. And you need salt replacement also. Now contrast this with the Gitelman. A 26-year-old woman referred by her gynecologist after a pregnancy complicated by recurrent hypokalemia and hypomagnesemia requiring IV supplementation. She has had chronic fatigue, salt craving, and muscle weakness since childhood. But nobody put it together until the pregnancy unmasked it. And that's actually typical for Gitelman. Late presentation is the norm. Many patients aren't diagnosed until adulthood. Pregnancy, diuretic use, or any intercurrent illness can tip them over from compensated to symptomatic. Her potassium is 3.7 on supplement, so it would be lower without them. Her magnesium is 1.2, which is significantly low, and she has orthostatic vital signs. Blood pressure drops from 112/72 sitting to 84/54 standing, indicates that she is volume depleted. The urine calcium to creatinine ratio is 0.04. That's well below 0.14 threshold, hypocalciuria, and the fractional excretion of magnesium is 12.9%. The kidneys are actively wasting magnesium. So hypokalemia, hypomagnesemia, hypocalciuria, orthostasis. This is Gitelman syndrome. And notice what's absent? No nephrocalcinosis, no kidney stones, because calcium stays in the blood. More clinical detail on Gitelman. Gitelman is caused by loss of function mutations in SLC12A3, the gene encoding NCC. It's autosomal recessive. Unlike Bartter, the presentation is often late. Patients may go undiagnosed through childhood. They complain of salt craving, muscle cramps, and fatigue. Pregnancy can unmask a previously indolent case because the physiologic demands of pregnancy exacerbate the electrolyte loss. And crucially, no nephrocalcinosis. That's Bartter's hallmark, not Gitelman's. Why do Gitelman patients get hypomagnesemia? When NCC is dysfunctional, it leads to decreased expression of TRPM6, the magnesium channel, on the apical membrane of DCT cells. Less TRPM6 means less magnesium reabsorption. There is also evidence of DCT cell apoptosis contributing to the problem over time. Treatment is lifelong and supportive. The key pearl here, and this was tested on the boards, is magnesium formulation. Magnesium oxide causes diarrhea, which worsens the volume depletion in a patient who's already orthostatic. The answer is to switch to magnesium lactate, a slow-release formulation that's better tolerated. Amiloride helps by blocking ENaC in the collecting duct, which reduces potassium wasting and may also improve magnesium retention through the effects on TRPM6. So why magnesium must come first? This concept applies beyond Gitelman. It's relevant anytime you see hypokalemia with hypomagnesemia. In the normal state, intracellular magnesium sits inside the ROMK channel and acts as a plug. It blocks potassium efflux. So potassium stays where it should, inside the cell, and not leaking into the urine. But when magnesium is depleted, which happens in Gitelman from TRPM6 downregulation, that ROMK channel loses its block, it stays wide open, and potassium just pours through it into the urine. This is why hypokalemia from hypomagnesemia is refractory to potassium repletion alone. You can give potassium all day, and the level won't budge because it's going straight back out through the unblocked ROMK channel. The clinical rule: you must replete magnesium before potassium. Fix the block first, then the potassium will stay. This applies to Gitelman, but also to PPI-induced hypomagnesemia, thiazide-induced hypomagnesemia, and any other cause of combined hypokalemia and hypomagnesemia. Is a critical board trap. You get a patient with hypokalemia, metabolic alkalosis, normal blood pressure, and high urine potassium. Looks like Bartter or Gitelman, right? Not so fast. Vomiting can present exactly the same way. The alkalosis from vomiting causes bicarbonate-uria, which drags sodium and potassium into the urine. So the urine potassium is high, even though this is a GI problem. So how do you tell them apart? Check the urine chloride. In vomiting, chloride is lost in the vomit itself. Gastric secretions are rich in hydrochloric acid. The kidneys appropriately retain chloride, so the urine chloride will be low, below 25 millicurrents per liter. This is a chloride-responsive alkalosis. Give them saline, and it corrects. In Bartter and Gitelman, the tubular defect means the kidneys cannot retain chloride. The urine chloride will be high, above 25. This is a chloride-unresponsive alkalosis. Saline won't fix it because the chloride goes right back out. The urine chloride is the key differentiator when vomiting mimics a tubulopathy, and boards will test this, sometimes with a patient who denies vomiting but is secretly purging. Let me explain why the urine chloride works as a differentiator. In vomiting, step 1, gastric HCl is lost, which depletes chloride and generates metabolic alkalosis. Step 2, the excess bicarbonate gets filtered and appears in the urine as bicarbonate-uria. Sodium and potassium are obligated to follow the bicarbonate out, so urine sodium and potassium are high. But urine chloride stays low because chloride was lost in the vomit, not in the urine. And then volume depletion activates aldosterone, which causes even more potassium wasting. So the pattern in vomiting is high urine potassium, high urine sodium, but low urine chloride. In Bartter and Gitelman, the transporter defect wastes both sodium and chloride. The kidney literally cannot hold on to NaCl. So urine sodium, potassium, and chloride are all high. The divergence, high urine sodium and potassium with low urine chloride, is the fingerprint of vomiting. In a tubulopathy, everything is high together. Now let me put it all together in a side-by-side comparison. On the left, Bartter, thick ascending limb, NKCC2, channel involvement, loop diuretic equivalent. Presence early, antenatal or neonatal. The defining feature is hypercalciuria with nephrocalcinosis. Treatment centers on sodium and potassium chloride repletion, indomethacin plus potassium-sparing diuretics at times. And on the right, Gitelman, distal convoluted tubule involvement, NCC channel is blocked, thiazide equivalent. Presence late, often not until adulthood. The defining feature is hypocalciuria, no stones, no nephrocalcinosis, and hypomagnesemia from TRPM6 downregulation. Treatment is magnesium lactate, KCl, and at times amiloride. Look at how these two cards mirror each other. Same general presentation, hypokalemia, metabolic alkalosis, normal blood pressure, but the calcium and magnesium tell them apart completely. So, three things to take away from this episode. Number one, the calcium trick. Bartter has high urine calcium above zero point 0.2 with nephrocalcinosis. Gitelman has low urine calcium below 0.14, no stones, one test separates them. Number two, the drug analogy. Bartter equals loop diuretic, Gitelman equals thiazide. If you know what those drugs do to calcium, you know the syndrome. Number three, the chloride test. Urine chloride below 25 means vomiting, above 25 means Bartter or Gitelman. And the bonus pearl, magnesium must be repleted before potassium. Hypokalemia from hypomagnesemia is refractory to potassium repletion alone because magnesium normally blocks the ROMK channel. That wraps up Bartter and Gitelman. Next time, episode 4, we are going into the mineralocorticoid axis. This is hypertension plus hypokalemia workup. We'll build the renin-aldosterone framework, how to sort patients based on whether renin and aldosterone are high, low, or discordant. We'll cover primary aldosteronism and adrenal vein sampling. We'll talk about glucocorticoid remedial aldosteronism, also mention Little syndrome, where the problem isn't aldosterone at all, but constitutively active sodium channel, and the syndrome of apparent mineralocorticoid excess, use of licorice, posaconazole, and the cortisol-cortisone shuttle. It's the biggest episode in series, and it maps to the most board questions. You won't want to miss it. Thanks for watching. See you in the next one.